also really made awareness that creating and developing a culture of well-being is not just an individual responsibility. On the contrary, it's a shared responsibility of each individual healthcare professional and the system, with the major responsibility lying within the system itself. It is a partnership between each individual healthcare professional to have that unashamed, unapologetic invitation in a culture that promotes emotional and mental well-being to care for themselves and to care for their colleagues in order to provide the best care to the patients and their families. Through all our conversations, we've also identified ways that can allow that culture to really be created. We've looked at it at the individual level, the group level, the organization level, and today we are really excited that Dr. Barron is really going to talk about that advocacy and what is available at the macro level to help us with the same thing. Before I introduce him, I just wanted to really highlight how important it is to have the support of the organization. And at Erlanger, in Chattanooga, and at UT, we have the support of the College of Medicine, our community with the medical society, and of course with the hospital. So I'd like to share some slides to really highlight the individuals that have made this possible. We've had a resident advisory board for a few years now, which has representation of the house staff leadership, but also key members from each program. So for those of you that are on the call today, if you want to show your faces, we can thank you in person. If not, please extend the gratitude to all your colleagues. They are your representatives that bring issues to us in the forefront. You all are with boots on the ground. And if we don't keep a pulse and listen to what each of you have to say, it would be very difficult to really change culture meaningfully. We have the WellBeing Task Force, which is again got representation from faculty members and leadership, and an interprofessional healthcare team, which is really responsible and at the forefront of the care that we provide. We've got leadership from the academic side, the institutional side, and also community. So thank you all very much for all you do and for your contributions to creating this culture. Before I turn it over to Dr. Amjad, who I will introduce in a minute, I just wanted to remind you all that we will be having the walk on October 3rd. We've had an outstanding support from our interprofessional staff, especially the nursing staff. Greater than 150 people signed up. I want to thank Ms. Ray Bond and Kevin Lusk from the Medical Society, who are really getting the t-shirts together. And this is part of a national walk that occurs every year. It's called Out of Darkness. And this year we are partnering with them to continue to raise that awareness. So thank you and hope you would support it. Now, one thing that we started with in the beginning was how can we really make this partnership that I spoke about and that has shown to have evidence, something that we remind ourselves each day. We know that the Hippocratic Oath is something that is timeless, and it lays a lot of emphasis on that altruistic motive. But we've also realized that our healthcare system calls for something different today. And to lead us in really understanding this partnership and making self-care and colleague care in partnership with our organization something that we will be active about, I'm going to invite Dr. Natasha Amjad, who is an internal medicine resident and also the chair for the WellBeing Task Force for the house staff, to lead us in pledging the Hippocratic Oath. She will read it out wherever you are. Please feel free to do it in community if you're with your colleagues or individually. Natasha, the floor is yours.
Thank you so much, Dr. Panda, and thank you for the opportunity to have this position and be able to lead this oath. So I'll go ahead and get started. We solemnly pledge to embrace and promote the well-being of ourselves, our colleagues, and the medical community as part of our responsibility to the effective care of our patients, ourselves, and in partnership with our healthcare organization. We will seek to develop and adhere to habits that promote and maintain humility, meaning, and wholeness of self in our work and interactions. We will be attuned to the physical, emotional, mental, and spiritual needs of ourselves and others, and share our practices of well-being for the benefits of our patients, our colleagues, and the advancement of healthcare. We will commit to integration and balance in our professional and personal life, and seek help when we feel we ourselves or our peers are overburdened, fatigued, or less compassionate. We will champion for a healthcare system that values the well-being of its personnel, uses best evidence for an institutional culture of wellness, and recognizes that in so promoting the patients that we care for are ultimately best served. We will find the courage to be vulnerable and confront professional wrongdoings to the best of our abilities, while at the same time showing compassion and respect for all members of the healthcare team. I make these promises of well-being to myself and to the vocation of the medicine with my highest commitment.
Thank you, Dr. Amjad.
Thank you.
Let's remind ourselves of these various tenets that we just pledged as we hear Dr. Barron really help us and guide us through how can we continue to enhance this culture. We're really privileged to have Dr. Michael Barron. He obtained his MD and MPH degree at Tulane University. He completed an anesthesiology residency at Washington University in St. Louis and psychiatry residency at Vanderbilt. He continues to maintain board certifications in anesthesiology, psychiatry, and addiction medicine, and serves as the clinical assistant professor at Vanderbilt University. He really specializes in chronic pain and addiction. He has a cornerstone article in 2006 that he published, his original research, showing that high-dose opioids actually increased chronic pain scores. He was appointed to the Tennessee Board of Medical Examiners in 2010 and then reappointed in 2015, and has served as the chair of Tennessee Controlled Substance Monitoring Database Committee for 13 years, and has helped write many different Tennessee Department of Health rules pertaining to the treatment of pain, prescribing controlled substances, and addictions. In 2017, he resigned from the above positions to accept the medical director position of the Tennessee Medical Foundation Physician Health Program and serves on the steering committee for the Tennessee Chronic Pain Guidelines. He's helped write the Federation of State Medical Boards policy on professional sexual misconduct and impaired physician policy, very recently as 2020. Dr. Barron also is a volunteer medical director for the National and Davidson County Drug Court. As you can see, he works at many different levels to ensure that we have a healthcare system that really supports us to do the work that we need to do on a day-to-day basis with the same altruistic motive. So with that, Dr. Barron, the floor is yours. Thank you for accepting our invitation.
Thank you very much, Dr. Panda, and I'm glad to be here, even though it's an hour earlier for me. I'm going to go share the screen back, I hope, and we'll see if this all works, and hopefully it works good. Good morning, everyone, and thanks for having me here. It does work, good. Physician Health and Wellness in the Physician Health Program. This is session 3 of Suicide Prevention Month, and some of the sponsors are the Chattanooga-Hamilton County Medical Society, the Medical Foundation of Chattanooga, LifeBridge, which is not listed there, it should be, and UT College of Medicine of Chattanooga. I have no financial relationships to disclose. I am also the volunteer medical director for the Nashville-Davidson County Drug Court. It's a 120-bed residential treatment facility for nonviolent offenders that have drug and/or alcohol issues. And it's a really very powerful program that costs about 25 cents on the dollar that we spend for keeping someone incarcerated. So I'm really proud to be associated with that program as well. The other stuff was nicely described by Dr. Panda, so I won't go into it. This morning, we're going to become familiar with physician health and wellness and differentiate illness from impairment. It's really important to learn the difference there. We'll learn about the stigma, the huge amount of stigma and external resistances of getting help for a mental health problem, and then become familiar with physician health programs and how and when to get help. And then we'll talk a little bit about the difference between licensing boards or regulatory medicine and physician health programs. But let's begin here. I need to move over a little bit. There we go. Talking about physician personality and how we're wired, because physicians are wired differently than the general population, but we have a culture of being wired that way. So it's basically normal to us. We need to start looking at why physicians are at higher risk for problems that we are going to talk about. We are perfectionistic. We aim higher than excellence, and perfectionism is not obtainable. We can't be perfect, but yet that's what we strive for, which is fine. But when we fall short, we get into trouble. We start to think we're not perfect, and we're not perfect. We're human. And I think many physicians forget that we're human. And certainly the general population forgets that we're human, and they want perfectionism, but that's not obtainable. We have workaholic tendencies. The average physician, average US physician works about 55 to 58 hours per week in a 40-hour work week. We have an 80-hour work limit for interns and residents. 80 hours a week are 2 full-time jobs. That's not the norm for the rest of the world. We have this Lone Ranger syndrome, the belief that we need to do everything ourselves. We come to work every day, we work hard, we prove our worth, we have a servant's heart, and we wear a mask. We put the patient first. And this is an ambivalent type of a role, because patients need to come first. But as we heard from Steve Lloyd earlier this month, the physician's health needs to come first. We leave our families at home ill to take care of somebody else that may be less ill than the family member we left at home. It doesn't make sense. And we don't put our own health care first, which we need to. We are told don't show weakness, have no emotions is another way to say that. And we see people on the worst day of their life and are not able to react emotionally. And then we move on to see the next patient on the worst day of their life. And we do this time after time after time. And all these emotions begin to fester into what's described as an emotional abscess. Because emotions are energy, and they don't come out in some way, either through emotive, expressive, artistic ways. They sit there and they make us ill. And we have this willingness to delay personal gratification for career goals. It takes, as we heard earlier with me, 7 years of training, 4 years of med school, most trainings about 3 to 5 years. And we always say, I'll be happy when I achieve this goal. I'll be happy when I graduate residency. I'll be happy when I graduate med school. I'll be happy when I make full professorship, get tenured. I'll be happy when I have this amount of money in the bank. I'll be happy when. And lately I hear a lot, I'll be happy when I retire. I'll be happy when I retire? Really? That's what someone's going to wait for, to be happy? It's a chaotic world, and we need to feel happiness in the present, not in the future, because we're not happy in the future. Happiness is a current emotion, and if we don't experience it now, we can't put happiness in the bank and store it up for later. It doesn't work that way. Dr. Glenn Gabbard, a psychiatrist that's no longer living, did a lot of work with physician health back in the 80s, kind of the father of physician health, if you will. And what he described in his work, that 80% of physicians have obsessive compulsive personality traits. And it's a triad of things of self-doubt. And what did I miss? So we check and then we recheck and we recheck labs, we recheck this. We have this excessive amount of guilt where, and it's not good kind of guilt, it's more on the shame side of guilt, where there's a sense of inadequacy. I'm a fraud, I got here by mistake. The medical school admissions made a mistake, or the residency program director made a mistake and accepted me. Now everyone's smarter than me. Many physicians, 80%, have those types of feelings. We have this exaggerated sense of responsibility where we overwork to clear our conscience that we may have missed something. Physicians have maladaptive ways that lead to burnout, to emotional illnesses like depression, anxiety, substance use disorders. These include difficulties in reluctance to take vacations from work. We don't use our allotted vacation time. Most physicians don't use their allotted vacation time. More than 50% of physicians are now employees. And they're given 3 or 4 or even 6 weeks of vacation time. And many if not most, don't utilize all their vacation time. They think they need to work. We have an inappropriate and excessive sense of responsibility for things beyond our control. So we take responsibility for things that are out of our control. That's just how we're wired. And we have these chronic feelings of not doing enough and difficulty setting limits. We confuse selfishness with a healthy self-interest. One of Gabbard's quotes that I really like is this: "Herein lies the grand paradox. Compulsiveness and excessive conscientiousness are character traits that are socially valuable, but personally expensive. Society's meat is the physician's poison." Those traits, those 80% that have obsessive compulsive traits, make a really good physician, but they could also make a really sick physician over time because they delay their gratification until they retire. So we need to differentiate illness from impairment. And these are really important concepts, not only for regulatory medicine, but just for in general to know when to get help. Illness is a human condition. We are allowed to be ill. We don't think we are, but we are. We are not allowed to work if that illness causes a functional impairment. Impairment is not permitted. Physicians are safety-sensitive workers, and a safety-sensitive worker, by definition, is a worker whose on-the-job performance impacts their own health and the health of others, such as an airline pilot, a train engineer, a physician. An example of an illness is the flu. We're able to get the flu. We get myalgias, fever, rhinorrhea. The flu is permitted, but we're not permitted to work with the flu. Number one, we're contagious. And if we have a fever, we're cognitively impaired. So people with the flu should stay home, but that's permitted. An example of impairment is alcoholism. Alcohol use is permitted. You're permitted to have a glass of wine, a beer on the weekends, whatever it is. But if that use turns into a disorder with consequences, that's impairment. And alcohol use disorder is not permitted. And it's important to understand that illness to impairment, many illnesses will morph into impairment, such as cerebral vascular accident. Someone has a stroke, they can be impaired and not able to work in medicine. When I was a medical intern at Charity Hospital, I did an internship in internal medicine at Charity Hospital, New Orleans. And Charity Hospital is we call it the free. It closed after Katrina, but it was a wonderful place to train. It was a resident-run hospital. And as a medical intern there, I had to do 1 month of 1 month in the medical emergency room and 1 month in the surgical or trauma emergency room. And I remember one night, we're on call every other night for 30 or 31 days. And one night in the trauma emergency room, I was making rounds with the chief resident, me, the second year, the third year, the fifth year, the chief resident. And the chief resident had an IV pole, was walking around holding an IV pole, receiving IV fluids. And he looked awful. He looked like he was about ready to be admitted to the medical emergency room next door. And I thought, what a cool guy, what devotion. And now, 30 years later, having some maturity and a lot more knowledge under my belt, I thought, what an idiot. If he was needing IV fluids, he should have been in bed at home or in a ward upstairs receiving IV fluids, not making rounds. He was impaired, but yet he was put on a pedestal by me and probably everyone else there, like, what a dedicated individual. There's 4 main reasons for referral to a physician health program, which is what the PHP stands for. And the 4 biggies are boundary violations, disruptive behavior, addiction or substance use disorders, and burnout syndrome. And since burnout is now so prevalent and getting worse with the parallel pandemic, I want to briefly focus on that and then talk about addiction or substance use disorders. Burnout was first described in the 80s by Christina Maslach. And it was not in reference to medical personnel, physicians. It was basically the US worker, but she described this triad of emotional exhaustion, just feeling emotionally depleted, frustrated, tired of going through the motions, thinking things like, I can't take this anymore. Detachment or cynicism, where there's just a loss of empathy for patients and others, seeing patients as a diagnosis or an object or source of frustration even, such as, well, the train wreck in room 1 or the UTI in room 2. And then having low personal achievement, where experiencing work and life as unrewarding. What's the point? All I did today was click a mouse, punch a key, and document for the billing. Just not very rewarding. Every day is Monday, every day it's raining, and just not feeling good about life or what you're doing. And all these things lead to depression, to suicide, to substance use disorders, and to bad clinical outcomes. And that's been shown over and over and over, and we'll talk about that in a minute. I really like this quote from Dr. Michael Myers, and he describes physician burnout syndrome in his book, Why Physicians Die by Suicide. Good book, I highly recommend it. But he says, physician burnout syndrome is the erosion of the soul, a lack of direction, and inability to take charge of one's work or life. It's a powerful book, by the way. So what are the symptoms of physician burnout syndrome? And it's physical, but more emotional exhaustion. Insomnia, early, middle, late, doesn't matter. Social withdrawal, professional boundary violations. People that feel that bad want to feel something, so they act out sexually, usually. Having disruptive behavior, they act out in other ways. They're impaired clinically. They're not very good at what they do anymore. They've lost that desire to form a therapeutic alliance with the patient. So they walk in the room and say, what's wrong? No, look at the computer only, not the patient. Type a few keys, here's a prescription, bye. And the patient says, man, that was terrible. They use substances. They get depressed. And it's a sequelae of burnout. It's not the same thing as burnout. And a recent survey of nearly 8,000 members of the American College of Surgeons reported that 30% of the respondents had positive depression screens. 30% of 8,000 surgeons. And they kill themselves. And regarding suicide, 60% of surgical residents with recent suicidal ideation did not seek help because it would affect their licensure. 60% of surgical residents that had suicidal ideations did not seek help because of stigma. A very powerful, powerful number. Burnout's not stressed out, completely different sides of the equation. Burnout's a low energy state. There's disengagement. Emotions are blunted. There's just no urgency, no energy. It's emotional, and there's increased risk of suicide. Stressed out is kind of a high energy state. There's overengagement. Emotions are overreactive. There's a sense of urgency. Damage is physical, like MI, hypertension, stroke. And there's increased risk of those medical conditions. So they're diametrically opposed from one another. As we can see from the statistics, burnout has increased, it started to decrease, and then bam, the pandemic happened, and now they're off the scale high. No one has done a recent study really to look at what the incidence of burnout is now, but we know it's way up, way up. Back in 2017, it was about twice that of the US general population of workers. So what are the drivers of burnout? And there's numerous levels of drivers, such as the individual level, the departmental or divisional level, the institutional level, and then at the national level, such as CMS and HHS. But the drivers that are important, at least important to me, I think, are having time pressure. If you need 30 minutes with a patient but are only allotted 8 to 12, you're always under time pressure. You're going to be running late. You're going to be stressed in a way that's not good. Having insufficient resources. If you run out of masks or PPEs or other resources, not good. Having electronic health pressures. And in my office, we snidely call this EPIC referrals. Every time a hospital system in Vanderbilt has switched over to EPIC in the last 2 years, and they started doing their satellite resources, every time a hospital or practice group changes electronic health records, we get referrals. And again, we call them EPIC referrals, even though they're not always, that's not always the name of the EHR. The leadership of the immediate supervisor is really important. How do we become leaders in medicine? Well, we matriculate up the ladder. So people become chief resident because they're at the top, but that doesn't mean they have good leadership skills. And if your immediate supervisor has poor leadership skills, you're much more likely to develop burnout. It's really a very important virtue. We have good leadership training in the state. The Tennessee Medical Association has a good leadership program, but it's not very well utilized. When there's discordant values between the individual physician and the place where they work, either the group or the practice, if those values are different, it's problematic. Work-life imbalance speaks for itself, really. And when there's loss of autonomy, loss of control, it's, in my mind, the same as having responsibility without authority. When you need to spend 20 minutes on the phone talking to someone out of state with a high school education to get a X-ray approved, very, very frustrating, and that eats away at you. And these little incremental eat away at you to, over time, develop physician burnout syndrome. And I really like this quote. It's from Richard Gunderman, who writes for The Atlantic. It's about how burnout can develop. Burnout at its deepest level is not the result of some train wreck of examinations, long call shifts, or poor clinical evaluations. It's a sum total of hundreds and thousands of tiny betrayals of purpose, each one so minute that it hardly attracts notice. Again, slapped over and over and over and over. So what are the consequences of burnout? Well, we have three realms of our world. We have home, social, work, or school, and burnout affects them all. On this slide, cartoon description, I have really the personal and the work. But on the work or the professional side, there's a decrease in quality care. an increase in errors. SVMIC and other malpractice companies are really aware of this, and they're really looking to address ways to minimize burnout because of this risk for litigation side. There's decreased patient satisfaction, which leads to malpractice lawsuits. There's increased malpractice. There's increased turnover, which includes early retirement. But on the personal side, it's even worse. It leads to depression, loss of pride in work, depersonalization, emotional exhaustion, including early retirement, change to administrative work or part-time work, relationship strife, divorce, marital relationships that break up, substance use and overt addiction, and divorce and suicide. When I was at WashU, the Department of Surgery there had 100% divorce rate. They're kind of proud of that. But the burnout that leads to suicide in September's Suicide Prevention Month, we need to talk about physician suicide rates because they're twice or more of the general population. In the general population, there's 13.8 per 100,000 suicides in the general population. 69% are pale male. The physician rate's about 2 to 3 times that. There's about 300 to 400 physician suicides per year nationwide, and greater than 25 resident suicides per year nationwide. On a prevalence, sorry, my voice isn't woken up yet, 28 to 40 suicides per 100,000 physicians. In the general population, females are more likely to attempt suicide. Males are more likely to end their life by suicide because they use more lethal means, gunshot wounds, hanging, things like that. In the physician population, male and female suicide rate is equal to each other. But as we said, females 130% higher than the general population of females, and males are 40% higher than the general population of males. Dr. Lorna Brennen is the poster child for physician suicide. She grew up in Virginia, was a New York trained Presbyterian hospital emergency medicine physician. She ran the emergency department at Allen Hospital, which was a New York, a Columbia hospital. She loved to travel. She had good friends, member of church, snowboarder, the cool aunt, things like that. On April 26, 2020, she ended her life by suicide. In a period of 3 weeks, she treated COVID-19 patients. She developed COVID-19. She had a moderate course. She was treated home. She recovered. She went back to work probably way too soon and was just overwhelmed with what she was seeing. And she got very depressed. And she left work, went home to Virginia, was actually put in an inpatient facility, left the facility, and killed herself. And it was the stigma that really killed her. Her sister is a lawyer and married to a lawyer, the Feists, and they became very active in this process. And I met them when I was doing some work with the Federation of State Medical Boards. But she was terrified of the stigma of not being able to return to work, of having an illness, of having depression. And she was fearful that she would lose her hospital privileges and her medical license, and that her career was over because she had depression. Her sister and brother-in-law then founded the Lorna Brennen Foundation to combat stigma and combat physician suicide. And they got the Center from Virginia to pass a bill, and it passed in the US Senate in August of just last month. And it aims to reduce and prevent suicide, burnout, and mental and behavioral health conditions among healthcare professionals. It's not signed into law yet. It still has to go through the House and then no to the president. But I think with the amount of energy that's behind this bill, it will pass. And the important part for me of this bill, the whole thing is important, but more to my house is that HHS, Health and Human Services, must study issues related to and develop policy recommendations on preventing burnout and improving mental and behavioral health among healthcare providers, removing barriers to accessing care and treatment, and identifying strategies to promote resiliency. The last part, the resiliency part, bothers me because physicians are actually very resilient compared to most other professions. Physician suicide is an occupational hazard. Suicide is the only cause of mortality that is higher in physicians than in the general population. So it's an occupational hazard. Suicidal ideation increases in med school. The prevalence of suicidal ideation in medical students was 11.1%. Within the past 2 weeks, 7.4% of med students reported suicide. And in the past year, according to the study, 24% had suicidal ideation within the past year. Regulatory complaints are associated with increased rates of suicidal ideation. In a cross-sectional survey of nearly 8,000 physicians in Europe, actually in England, in the United Kingdom, physicians without a regulatory complaint reported suicidal ideation at a rate of 2.5%, but this increased to 9.3% for those with a recent or current complaint. And suicidal physicians face unique barriers to care. Stigma. These are due to concerns regarding confidentiality and fear of discrimination in licensing and applications for hospital privileges. And we'll talk more about that soon. I need to speed this up, sorry, but this is a really important video that I want you all to hear.
Medical training is challenging.
It can be frustrating,
Exhausting.
overwhelming, especially when things pile up on you.
My marriage is coming apart. I took out $183,000 in loans.
I made a mistake, a bad one.
Sometimes I feel like I'm in over my head. I just don't feel prepared.
Sometimes I think the real mistake was thinking I could be a doctor.
We all have our ups and downs, but if somebody starts acting really down,
Not able to sleep or sleeping too much.
shutting her friends out, giving her stuff away,
If somebody just doesn't seem like himself, not doing things he used to love,
Showing up late, not getting things done.
if somebody starts acting reckless or irritable,
yelling at nurses, snapping at patients.
Drinking too much.
He might be feeling burned out or depressed or hopeless.
people who are smart and talented, they get overwhelmed just like anybody else.
And when they do, they may find it even harder to ask for help.
Medical students and residents have higher rates of depression and burnout than other adults.
they have a high risk of suicide too.
That's something we all need to understand, the risks and how to look out for ourselves and each other.
And when it happens, people say, I had no idea. I thought he was just upset.
I thought she'd get over it.
I wish he'd come to me. I wish he'd said something.
I wish I'd said something. And now it's too late.
Suicide can be prevented. If someone you know is acting differently or really down,
Don't assume he'll get over it.
Say something. Say, are you okay? How can I help?
The best way to prevent suicide is to show you care and get the person the help he needs. So don't be afraid to ask straight out, are you feeling so bad? You're thinking about taking your life?
People want someone to ask. They want someone to care. Faculty, peers, friends, anyone can ask.
Are you thinking about killing yourself?
And if she says yes, or maybe, or sometimes, here's what you don't say.
That's crazy. One mistake isn't worth killing yourself over.
that's not going to solve anything.
What you do say is, I'm sorry you're feeling so bad. How can I help?
We'll get through this together. Let's get you some help.
Assume you're the only one who will reach out and get this person the help she needs.
None of us should be ashamed of getting help.
Getting help is the strong professional thing to do.
Let her know she has options, that there are people she can talk to.
Let her know she can always turn to you.
Make sure she has the National Suicide Lifeline number.
And help her find someone she can talk to, someone who knows how to help.
Ask the Dean for Student Affairs or the Program Director.
If you think she's about to hurt herself, don't leave her alone.
Take her to the emergency room. Call 911 if you have to.
We all get down. We all have our bad days. But sometimes it's more than that.
If you think something's wrong, the only way to find out is to ask.
Are you thinking about ending your life?
Don't wait until you're sure. Trust your gut.
It never hurts to ask. It never hurts to care.
It can make a big difference.
Any one of us can make a difference.
All the difference.
In someone's life.
That's used with permission by the American Foundation for Suicide Prevention and the Mayo Foundation for Medical Education and Research. Substance use disorders is another big risk factor for physicians. In this picture is Dr. William Halsted and Sigmund Freud, two people that had addiction their whole entire career until they died. The physician risk factor is really the same as general population. Genetics plays a huge role. Choose your parents well. I always told my patients, they always looked at me kind of funny. Medical students that enter into medicine generally come from wounded families, 60 to 75% do. Physicians have easy access. As we heard from Dr. Lloyd, no one escapes training unscathed. So we developed this PTSD symptomatology in our training. We learn to turn off our emotions. The anesthesia, the American Board of Anesthesiology has films such as Under the Mask, ways to express emotions when we're not allowed to express emotions. We learn to not ask for help, and we start to prescribe to ourselves. And self-prescribing is a form of self-medicating and a precursor for addiction. How do these symptoms present? Generally, friction with partners, administrative staff, family, marital difficulties, withdrawal from social events. There's personality changes of Jekyll and Hyde. Physicians obtain hallway consults for controlled substances. The important statistic here, work performance is typically not impaired until the more advanced stages. 43% of opioid using doctors have been using opioids for more than 2 years before detection. Physicians, 50% use alcohol, 30% go to opioids, and 20% are the other hodgepodge, including cannabis. And it could also be looked at like specialty. Different specialties attract different personalities, and same thing with drugs. Certain specialties with those personalities are attracted to certain drugs. The other important concept is that I never met a physician that used opiates that did not divert opiates for their addiction. Most, if not all, physicians with opioid use disorder broke prescribing rules and laws by diverting drugs. And physicians with alcohol use disorder have driven impaired. And yet we still get surprised when a physician with addiction breaks a law. These are called behavioral illnesses for a reason. Addiction causes aberrant behavior, even in physicians. Most docs don't go to the street for the drugs. They go to their prescription pad. Asking for help is a sign of weakness, and that's something that I hopefully you will never hear again or never realize, but it's still ingrained in the medical community. Medical students and trainees with burnout or depression who sought help were twice as likely to get negative judgment by a supervisor. Getting help was frowned upon. We heard about eating and drinking 2 weeks ago on Lunches for Wimps. If we're in an 80-hour work week, how do we get help? There's no time to make an appointment. And if we try to ask for time off, that's also frowned upon. There is a rational fear of getting help. Physicians are concerned that having a mental illness could make it harder for them to obtain employment, licensure, or hospital privileges. To improve the physician access to mental health, the AMA recently adopted a policy to encourage state licensing boards to require disclosure of physical or mental health condition only when a physician is suffering from a condition that currently impairs his judgment, not 5 years ago or 10 years ago or ever, but just if it's currently. I think that's really important, and I don't have time to read the whole policy. Sorry about that. But I do want to talk about this case very, very quickly. In April, we referred a PGY5 resident from the Hamilton County area, and I have his full permission to discuss this case. Like many of our physicians with addiction, he was initially prescribed opiates for a legitimate reason, having back surgery. He was prescribed opiates on and off for the next few years, and in 2018, he just lost control of his addiction, and he began writing fraudulent prescriptions. In April, this became known by the residency program director, by the hospital, and by the police. He was very appropriately and quickly referred to us, and within 48 hours, he was in treatment for an opioid use disorder. He spent 12 weeks in treatment. Upon discharge, he signed a 5-year monitoring agreement. Early in his treatment, I was in contact with the GME office there, and all things looked good that he would be welcomed back into residency. Unfortunately, the criminal aspect was delayed because of the ongoing pandemic, and he was eventually charged but not convicted with numerous counts of prescription fraud. And his contract was not renewed, and he was not permitted to finish the 4 months of his residency. He had already completed 4 years and 8 months. I think the criminal charges really scared everyone, even though there was no conviction. What happened eventually is that he did get judicial diversion, which means no conviction. And if he stayed healthy and good and out of trouble for the next few years, the charges would go away with no record whatsoever. Although his clinical outcome was excellent, and despite going up the appeal process, I made a lot of people angry at me because I was strongly advocating for this guy. But he was not permitted to return to complete his residency. And this greatly adds to the stigma of people reaching out to get help. We as a profession need to do a much better job at allowing our physicians that have illness to get help without punitive action. Punitive actions increase stigma, which decreases quality of care by scaring those that need help from getting help. He has done well, however. He got another PGY5 position and is now completing his urology training. Got married, he's happy, he's doing well. But the consequences of not being allowed to return to finish his residency permeated throughout. And I think this had significant consequences and resulted in increased stigma for those that came after him. So what are some of the other barriers to accessing care? Well, the physician personality. Things like, I need to do this myself. Only I'm able to do this. I need to go to work even though I'm sick. We're programmed to cope alone. Physicians handle stress alone and don't reach out because they fear looking like they're weak or a subpar doctor. We have survival mentality, and we have, and imposter syndrome. Many physicians think I should be able to take care of myself. I must not be a good doc if I get sick and can't take care of it. We are changing stigma though. However, and I'm very proud of the Tennessee Board of Medical Examiners under the leadership of then President Reeves Johnson for implementing a safe harbor clause in our renewal application. And also Dr. Melanie Blake for implementing other changes that are undergoing now. The Federation of State Medical Boards, the mothership of medical boards, basically encouraged to approach physician wellness and burnout from a non-punitive perspective, avoiding public disclosure of any information about a physician's diagnosis during the licensing process, and offering safe haven non-reporting options to physicians who are under treatment and in good standing with the recognized physician health program. This is hugely important work. The AMA is for it, the FSMB is for it, organized, the House of Medicine is for it. But yet hospitals still have these very intrusive questions that actually violate ADA, American with Disabilities Act. They still ask these questions. I'm working with Ascension Health, a large hospital system with 4 hospitals in the Nashville area, to change their privilege, their questions to get hospital privileges, to remove those intrusive, stigmatizing questions. The FSMB proposed question that decreases stigma basically says, are you currently suffering from any condition? Same thing like the AMA said. That's a yes or no answer. The renewal question for the Board of Medical Examiners basically says, no, if you are an anonymous participant in Tennessee Medical Foundation and are in compliance with your contract, you may answer no to this question. Really important work that we've done in this state, but we still have a long way to go. Again, stigma has a long association with mental illness, forcing people to suffer in darkness. Until we make intentional, directed efforts to dismantle the institutionalized stigmatization of mental illness, we will not move the needle on the epidemic of mental illness and suicide. I'm going to close with the physician health program. And I really loved Dr. Cunningham's high walking bridge analogy. That really moved me. And it's a great analogy of also what we do at the physician health program. Physician health programs, in a global sense, almost every state has one. California, Nebraska, and Wisconsin do not have one. California had one, but Governor Schwarzenegger dismantled it for some political reasons that are way beyond the scope of this talk. Physician health programs are a confidential resource for physicians, trainees, and medical students suffering from potentially impairing conditions. PHPs facilitate the early detection, intervention, evaluation, treatment, continuing care, and monitoring longitudinally over time. I'm going to talk more about TMF in a second. We got started as an offshoot of the Tennessee Medical Association back in the 70s, before many of the current residents and interns were even born. We've had 3 full-time medical directors. I'm number 3. So the medical directors last a long time here. We are a independent 501c3, separate from the medical board, separate from the Tennessee Medical Association. We're our own entity, but we're considered a QIC, Quality Improvement Committee, which means many things, but also means our charts are sealed. They are not open for court order or subpoena. We currently have 225 physicians that we monitor. We're referred about 150 to 200 physicians per year. Unfortunately, colleagues are highly reluctant to confront a substance use issue. Death from suicide or lethal overdose is often the initial presentation of a substance use disorder. About half of what we do is related to substance use disorders. The other half are other behavioral illnesses, boundary violations, distressed or disruptive physicians. In the last 20 years, we've helped over 2,500 physicians. Tennessee has 16,000 licensed physicians with a Tennessee address. And over the last 20 years, we've helped 2,500 of them. Obviously, that's apples and oranges, since incidence and prevalence are 2 different things, but still, it's a huge number. We already talked about how this process works, but we have a confidential tract. So a physician that's referred by themselves, their spouse, significant other parent, chief medical officer, medical executive committee, chief wellness officer, or even law enforcement, we will take care of. And the physician is evaluated, treated if needed, and returned to work and monitored without licensing board involvement. So there is no risk of punitive action if they follow through with what we ask of them. And what we ask of them is to get healthy. So we take an impaired physician and we go to repaired. And that's really important to know. When confidentiality is ensured by PHPs, physicians with potentially impairing illness are much more likely to come forward and utilize a PHP earlier in the disease process, which reduces the likelihood of the illness progressing to impairment and improves quality care for a physician. Physicians in states without a confidential non-disciplinary tract are often fearful of the process and are hesitant to admit their need for help. Colleagues are more reluctant to report a potentially impairing physician as well. There's a mandated tract, and that's when the physician is referred by the health regulatory board. And we treat the physician the same way, but we also then send compliance letters back to the board to ensure that the board knows that the physician is doing well. There, unfortunately, is usually a accompanying punitive action, such as a reprimand or even probation on license when it goes through the board. So if a physician waits until some disaster happens and they get referred to the board or a complaint is made, that's a disaster for the physician. So an example is when the physician goes to work drunk. They know they've been drinking, everyone knows they're drinking, but they finally show up to work drunk and a patient smells alcohol on them and the patient makes a complaint to the board. By that time, it's too late to help the physician in a confidential way. So I'd urge any physician that is having trouble with alcohol or drugs or depression that needs help to give us a call before it becomes a patient care issue. We have also developed and this was launched on February 3, 2020, just prior to when the pandemic happened, the Professional Screening Questionnaire. And this is a new web-based screening assessment and referral program to address increased incidence of suicide, depression, and burnout. This is free, it's anonymous, and it's confidential. There is backside help by a psychiatrist that can chat with the person utilizing this platform anonymously. So either they chat through the website or they chat, or if the person gives an email that's accurate, they could chat by email. This, we've had over 368 users as of last Friday. And this is a proactive resource to get people the help they need. 80% of those 368 were not getting help anywhere. So we are reaching a population that isn't getting help, that needs help. I'm very proud of this. We're the only physician health program that utilizes this. Again, this is an anonymous, voluntary, and free. The outcome is completely driven by the user. And this should help to address fears and asking for help, period. This is a link for the Professional Screening Questionnaire. And then this is the information for me. Thank you very much for your time. I am 1 minute overboard. I apologize for that, but I will hang out for questions if there are any. Thank you very much.
Thank you, Dr. Barron. A lot of information, but a lot of valuable information about the tremendous work that is being done at a state level to help physicians. I'll open it up to questions. Are there any questions or clarifications?
Hey, Dr. Barron.
Yes.
Hey, this is Ravi. I'm one of the resident representatives for TMA as vice chair for the state. And I really loved your talk, just talking to us about the highlights and insights of how prevalent burnout and suicide really is, even in Tennessee. For the residents and fellows in the state, how can we get more involved in spreading this awareness? What kind of programs are there for us, and how can we get involved to spread it to other residents to let them know about this?
That's a great question. And there's not a lot of ways to get involved with what we do here, but we do have brochures, postcards, placards for walls for like residents hang out. So I think asking for those, we could mail them to you to hang out. Also, just knowing that a program exists, I think at orientation, I'm involved in orientation with Ascension, hospital systems, HCA systems, and ETSU. So I think having some presentation at orientation is really helpful, that there is a physician health program in the state. Most residents don't know about us. So I think just getting the word out and having it available when somebody needs help is really key and crucial.
Great. Yeah, I'll definitely bring this up at our next meeting that we have as a governing resident council and see if we can kind of push this forward and highlight it, whether it's on our website or email newsletters that we'll be starting to put out.
Great, thanks.
Hey, Michael.
Dr. Johnson.
Hello. Good morning. Great job. You see, I have my little grin though, everything. I got most of your talk. I guess one of the questions I had, and I did want to say I appreciate all the work you've done for the Tennessee physicians at TMF, not only in the state, but also in the national level with your association with the National Association of PHPs. Several years ago, they started the restriction in hours that residents were supposed to have to work. And, you know, it's been quite a number of years ago. Was there any downtick or changes in depression, physician suicide or anything because of that? And has there been any change yet with those numbers with the inclusion of the changes in the application questions that the Federation recommended and that we in Tennessee have done thanks to your help rewriting those questions? Have you seen that at either time?
We do know for sure that in those states with a confidential tract in the physician health program, they see a lot more referrals than where everyone has to be reported to the medical board. Some states, the PHP does not have a confidential tract, or they have to let the board know, just know a name that no, these are who we're monitoring. Those programs get very few referrals. So we know that confidentiality really increases referrals. An 80-hour work week is still a huge work week. So I'm not aware of any statistics that show that there was a great improvement in mental health or mental health resources in that decrease in from unlimited to an 80-hour work week. Maybe Dr. Panda knows. I'm not that involved in medical education, so I'm not aware of it though.
Yeah, I agree with you, Dr. Barron. There wasn't much difference, and actually after that, the surgical specialties have they've gone back to the original. They had instituted the night float system to really help with the duty hours. But then there's a study going on where some programs enrolled in the original where they did do 24-hour call. I'm not aware if those results are still published or not, but there was not much difference in the overall rates of burnout or engagement or stress reduction based on the duty hours.
Thank you. Any other questions before I go back to bed? I eat breakfast and walk the dog. Thank you very much for your time. Dr. Panda, thank you for the work that you do and inviting me.
Thank you very much. And the video that Dr. Barron shared has been shown before, and I appreciate him showing it again. We will definitely be adding the link to our website. So if those of you want to see it again, as will be the recorded presentation from today's session. Thank you all very much. Have a good rest of the day and weekend.